Thank you, Dr. Gaurav. I'll be showing.
Thanks, Dr. Mahipal, sir, for sparing time and coming for this session.
I've just across. Can you give me video? I'll be showing you deferred lenticule extraction. That is called as the smooth incision lenticular keratomelusis or the silk procedure. And can we have the parameters on the screen, please? A young, beautiful girl, she's age? So these are the parameters. She's 24 years old, and we have fed this. These are the parameters that you can see. On the parameters, you can see that there is a slight nomogram adjustment that we have. So it is 4 diopters, which we have made it into 4.25. That's a slight overcorrection with the nomogram settings that we have, and a cylinder of 0.25. So this is the sphere adjustment and the cylinder adjustment that we have done. So from 4.25, we have done a sphere adjustment of 0.68. In this particular case, and a cylinder adjustment of 0.03. So the ultimate correction that we are going to do is minus 4.93 and 0.28 in the. So just to tell you that there is a nomogram adjustment that has been done when we started the clinical trials in January 2020. The results, we were getting slight undercorrection. So to overcome that, there has been a nomogram adjustment, and this nomogram adjustment for the sphere is we add minus 0.25 and 5% of the refractive error as regards the sphere. The second nomogram adjustment that came in was for higher myopias also. We just increased a little more, as also for the cylinder. So that is what I am talking, that these are the adjustments. That means that instead of 4.25, we added 0.68 and 0.03 because the cylinder is very small, which is only 0.25. So this is the nomogram adjustment that has been done. In the cylinder, the keratometry is 44.6 and 45.5. You can see here that including the optic zone is 6 millimeter, and the total zone for which the laser is going to fire is 7.6 millimeters. And this is the entry cut, which is 3 millimeters that we have. You can see that this is a biconvex, This is a biconvex lenticule shape which is there with a side cut angle of 60 degrees. The residual bed thickness comes, which is 325 microns. Total thickness is 88 microns. So this also, like the Visumax system, for those who have worked, has a flat add. That means that there is, if you have thinner cornea, thinner lenticule, then you can add a flat add, which can be from 10 microns to 30 microns. So which does not cause any refractive change. So that is what you can add. And this flat add is within the biconvex lenticule. It is not on the top of the lenticule. So this flat add, you have to have minimum of 10 microns. That is there. That is part of the machine. So this is what I was telling about the flat add. And you can see that the depth at which we are making the cap is 110 microns. So this is the settings that we have. So you can see here, this is the 0-180. I'll just mark it a little more. So this has to be marked in the OPD. We're just making it a little more. There's a manual cyclotorsion that is there, as also a manual centration which is there in this particular
now
case.
Now we ask the patient to kind of look. So we have to track the visual axis. Bete light mein dekhna. With one eye, we have marked the center. You can see that's the center mark that we have done.
So this is the visual axis that is being marked.
Once the center mark has been done, we are ready, because this will help us, because it's a tight dock, so it will help us in also centering on the visual axis. So you can see that's the visual axis. Now let's go on to the PI. You can see that this is the interface that we have. Open it.
This is a single-use patient
interface. This consists of 2 pieces. So we'll just take out the first piece. This is what goes onto the eye, and this is what goes on to the undersurface. You can see this goes on. They have lashed it onto the undersurface, and once it is lashed, you will put these into the suction.
So I think within the end of this year, hopefully it will become a single-piece patient interface.
That's on the machine.
Just now it is 2 pieces. We'll get a single piece.
Approve the readings that I had shown you.
And you can see that this is the scanning of the PI. So every PI first, before we actually go ahead and do the laser. So this is completed. And now,
So the PI scan is actually for giving you whether there is any tilt or there is any difference in the thickness of the patient interface, right? So if it is, then it will be rejected and you cannot move forward, okay? So this is an auto test that the machine does.
we
So
can
there is that red blinking
just
light,
go on and
patient
proceed.
will be looking into it.
Cornea.
Always moisten the cornea
So,
slightly
बेटे, अभी आपको
because
सीधे
otherwise
देखना है,
you can get
would
dry
want to
spots
moisten
on the
cornea a little bit.
laser.
And light बंद light सीधा देखो बेटे light में. So this is the suction ring. You can see we are placing it at 0 180 suction on. So suction is on. Low bed
This is
We
the
bring
red
the
blinking
bed
light that the patient sees.
below.
The bed can be moved up as
Once
also
we
the
have
machine
brought the
can come
bed
down.
down, now we will bring down the alignment, the PI onto the so you can see we are bringing down ऊपर कर maximum करना. Okay, so we'll go down. You can see that the patient interface is getting docked. This is as we go in. ऊपर कर.
So now you come in the green zone. This is important that you are in the green zone. This
So you
shows
can
that
see
your
this.
pressure is adequate.
Okay.
You pinching the thing, if you can
So you
watch
can
here,
see
you are
this is
pinching the
the
grabber
perfect
and
dock that we have.
this is more
Now
than 10
we have to
millimeters.
do
Can you
the-
see this white ring? It is beyond the white
So
ring,
we
10
have to remain
millimeters.
in the green part. You can see there is a docking which is about 40 to 50. We keep it on the green. Now you can see that there is a minute cyclotorsion adjustment which we will do. First the centration. You can see we are bringing on the onto the center where we had marked. Okay, this is the cyclotorsion adjustment, which is 4 degrees, which has been done, though it's only a 0.25 cylinder. We are ready now for the treatment. Bete hilna nahi ab.
So now the foot comes.
Machine is set now. Estimated time 16.6 seconds, and this is the laser that is being fired. This is the posterior part of the lenticule that is fired. This is the side cut. You can see how fast this laser is. It is showing 52% amount of time remaining. This is the anterior cut, and you can see that this is the entry cut that has been made. So once this is done, you can see that's the end of it, and the machine will auto undock, and it will just get raised. We can bring it back. We can bring the machine back onto the.
So there's a microscope. The machine
Now you
doesn't
can
come
see
with a
this is
microscope.
the-
You have to use your own
Bete light
microscope.
mein dekhna. This is the lenticule that has been created. You can see the eye looks pretty quiet. सीधा देखिएगा. Light को देखो आप बेटा. The entry cut, as you saw, went over several times. So this is the most easy to enter. Now what we have to do is that we have to go upwards because it's hilana nahi beta, because it's a biconvex lenticule. So you can see this just going upwards there. Okay. On one
That's
side,
anterior
now
to the
we go
lenticule.
posteriorly.
It's posterior to the lenticule.
Cornea.
You can see these are two separate planes that have been
Having
identified.
identified both the planes, सीधा देखो बेटे, लाइट को देखो, लाइट को.
I use a blunt spatula and I don't use a holding forceps because sometimes patient feels pain and the patient
So you
can
can
hear
see
it.
here that there is hardly any dissection that we have to do. It's like going through a knife going through warm butter. सीधा देखिए लाइट को. And again we go into the posterior. Again you can see that the mark is not coming into the way of the separation which you could see. And as we go, you can see very little dissection is required. There is a separation that we do from one side first, and then go on to the cornea wet karo, then go on to the other side, and this you can see is the finishing of the dissection. You could see that there is hardly anything that was required onto the dissection. So you can see that.
So that's
you
the
can see
lenticule
that
being
full
taken
lenticule, no problem.
out. You can spread the lenticule and see that it is complete.
The complete lenticule that you get out. And separation,
So
because this is 1 micron and no spot and line separation. Therefore,
So I'll
almost
just, so that is the end of the procedure. The important thing in this machine is that you can do a centration on the visual axis. You can do a cyclotorsion. The spot size is about 1.3 microns. Each spot, there is no spot separation and there is no line separation. And because of that, you get almost zero dissection or minimal dissection. So 90% of the times the surgeon felt that there is almost zero or minimal dissection that is required. There have been there hasn't been any instance with us. Now there are about 25 units that are installed in the world of suction loss, because the suction is pretty tight. People often ask a question, how much? So it's about 50 millimeters of mercury that the pressure goes up to. And what else? Dissection is very little that is there. Biomicroscopy on day one, you get clear corneas, and we have got within plus minus 0.5 which has been published. This is our study and NN study, and then Croatia, and then Singapore. So that we have got is more than 92% of the cases, and the visual recovery is pretty good. So now this machine is commercially available. We were happy to be involved with the first procedure that was done for the flap. This machine today has a flap and it has a lenticule. So the first flap procedure was done in December 2018. The first lenticule was done on 5th or 3rd of January 2020. So it's been 4 years plus since we have been working, and now it's available. I think Ajay is using this machine also and I think there are about 8 installations of this particular machine in India. Thank you very much for seeing this particular video. Thank you.
Thank you, sir, for bringing that overview of the silk procedure. And I think that biconvex lenticule again has its own advantages.
Yeah, so biconvex, there are 2-3 advantages. The first advantage is that because it's biconvex and not plano-convex, the nerves don't get transacted right at the plano-convex. So it's like going this. So the Rohit's group has shown that the dry eye is still lower as silk as compared to smile. The second thing is that he has shown also on confocal microscopy the nerve regeneration being faster. The other thing is that the induction of abrasions, whether it be spherical abrasions or higher order abrasions, is minimized, because biconvex lenticule is the shape that all, say, a good camera lens, for example, would be a biconvex lens, and it will not be a plano-convex. The other thing is, because it's biconvex, it has been shown that in smile or in silk, whatever in the lenticule, there are ridges in the Bowman's membrane, which has been reported by the Chinese, which takes a little while to go. That is why the clarity of vision may take a little longer. That's what was thought earlier. So here, the biconvex shape, the thing fits in better. And again, this is NN's work that they are showing that the Bowman's has less undulations in the silk procedure. But in any case, I think lenticule is the way to go. We have been on the lenticule for more than 10 years, and our group, Rupal, was the first person to do the silk procedure the way, the smile procedure the way it is being done in the world. And we were happy to be part of this trial and now have the approvals.
So what about cyclotorsion control? Like just like on the Catalyst, they have now linked it with the 700.
Yeah, they are going to link it to the IOL Master 700. They are also looking at, we have put it as the lower priority. The two priorities, that is what I have said is that I need the ammunition in my arm to do a spot and a line separation. A spot and a line separation is allowing us, or just a spot separation, 1.3 spot separation of 2 microns has reduced the quantum of energy going into the cornea by another 48%. So that is my first, because see, when the basic thing in a femto is a bubble hit, it expands. So you're not giving any space for the bubble to expand because it's superimposing on each. So that is what my first priority is. Second is a single piece PI. Third is hyperopic correction. Fourth is linking this to IOL Master or to the eye design. And they are looking at wavefront treatment also with this, but that's, I think, will be taking a little longer. But yes, IOL Master 700 just now has been linked to the catalyst, so I think they can link the thing. So possibly they'll be able to link it, but the linking has also been done with the eye design on the custom view. So their engineers have the propensity to link. So I think that linking will help you in the torsional correction of it.
What about astigmatic corrections? Like, are you, because
I
you've
have
been
done
doing
up to
SMILE
minus
before,
5 diopters flat. Like
do you see it doing much better than what you were doing with the Visumax?
I was a little apprehensive earlier, but because there is a cyclotorsion alignment, I am getting good results. I have got 20/20 with a 0.25 remaining in a -3 with -3.75 SIL. So the results are pretty good. I don't have any apprehension in doing a cylindrical correction in this.
Thank you,
Thank
sir.
you.
Thank you, sir.
Thank you very much for an excellent talk.